Good afternoon, ladies and gentlemen. I warmly welcome you to this particular session that is exploring barriers, from barriers to access, addressing HPV vaccination disparities in Nigeria. Just as a way of intro, before the panelists begin to come in, I would like to just show us what some of the barriers are from that he has been doing from our stakeholder dialogue in 14 states, including FCT. And that cuts across 6 geopolitical zones in Nigeria. And that's a fallout of our work on the Nigeria's survey on gender norms, research, and health for adolescents. So please, yeah. Okay, so, yeah, the next slide. Okay, so we know, and we have experts in this room who can collaborate that it's well known that cancer is a killer among African women and even the world over. And of course, we know that 90% of these cases are preventable with the vaccine that we have. But however, coverage across Nigeria is below 20% if you look at the data critically. But we also, from PIC, as I mentioned, we try to explore what are the norms, what are the behaviors, the drivers of these, the uptake of HPV vaccination in Nigeria. And that led us to conducting dialogue in states across 6 geopolitical zones in Nigeria. And we found that, of course, entrenched social norms, myths, misinformation, and system gaps block girls' access to vaccine. And of course, among all the barriers and the gaps, we found the major barrier is community norms. All these cutting across information across norms around infidelity and that the vaccine is meant to control population in Nigeria. And of course, there is this issue of stigma and silence around sexual reproductive health that we all know. Nobody wants to talk about it, nobody wants to listen to it, and nobody wants to accept that these issues are critical and living with us. And even when people accept that these issues are critical, they don't accept that, the society does not accept that they should be discussed, especially among adolescents. And then, of course, we know that parental refusal and community gatekeeping limit consent too. Parents don't give consent, and even when girls want to take up the vaccine, they also do not do that because they need parental consent to do that. So that validation, inability to validate that process, hinder the access to the vaccine. But then there's also the issue of misinformation and the media. The media propagates rumors. They propagate across social networks, across families and individuals. And also, there is also lack of coordinated impacts across the society, across Nigeria. Efforts are being made, but it's not well coordinated. So there are system gaps, actually. Yeah, so, and then, of course, there are also issues with adolescent engagement, especially among out-of-school adolescents, we know, because at a time the vaccine was introduced through the schools and distributed through the schools. So people who are not in school are left out. And then, but also some outreaches that are ongoing also focus, just very few of them focus on adolescents, ideally. Then there are system gaps comprising of weak integration into school health programs, weak follow-up systems for doses and boosters. People take the first dose. They don't go for subsequent doses, right? And then even when they are interested in taking the subsequent doses, vaccines are not available sometimes. But also, we also found limited training and hesitancy among the health workers. That's also an issue. Some health workers want to administer the vaccine, but they are not well knowledgeable about it. We also know that even where efforts are being made to train the health workers, several initiatives, several projects did that in the last 2-3 years. But JAPA, the reality of JAPA has hit. So people who already have the capacity to administer the vaccine and monitor its distribution are there. But then the policy and financing. The initiatives are willing to carry on that advocacy, but the truth is the money there? No. And if you look at the budget of the country at the moment, the money to distribute it and to sustain the outcomes, the efforts of the initiatives that are distributing it currently is not there. So these are some of the issues that we'll be exploring. Yeah. And so for this section, we expect to hear from the panelists as they dissect and confront myths and misconceptions surrounding HPV vaccination, and also how to reshape the norms. How do we move from understanding these norms to designing strategies and implementing actions, replicable models that can shape norms and also increase access to HPV vaccination. And then also, I already mentioned that the issue is about behavior, is about norms, driven by multifaceted factors. And so these are some of the things that they will be exploring. But the last, but not the least, is how do we connect the national policy promises? A lot of policies, a lot of promises are being made through strategic, through policies, but the issue is how do we connect these policies to real action? How do we action the solutions that have been proposed to make sure that this vaccine is distributed equitably and that invariably the cancer is prevented as a result of the gains from the vaccine distribution? Ladies and gentlemen, please permit me to introduce and welcome the moderator for this session. He is in our midst, and he's a distinguished scholar and practitioner. Welcome, Dr. Ishak Lawal. He will be the moderator for this section. Doctor, you're welcome.
Yeah, good afternoon. After this launch, a very difficult time to have meaningful engagement. If we're in these workshops, we'll say they do atama. I'm sure most of us know that, but yeah. So I welcome you to this session with the title Barrier to Access, Addressing HPV Vaccination Disparities in Nigeria. And PIC, we thank you for organizing this session, very apt. And distinguished panelists have been put together from various aspects of the continuum of care required in HPV vaccination. In no particular order, I'm going to call them to the table so that they join us in having this brilliant discussion. So I will start with Dr. Chito Nwana, the CEO, MD of Tabitha Medical Center. Yeah. Thank you. And then next on the list for me is Professor Amos Bassi, a public health specialist, the Deputy Provost of Nile University and a staff of the GSI. And if you know, GSI is one of those organizations in front of HPV vaccination in the country. Last but not the least, we have Abisola Kintolire from Clinton Health Access Initiative. And all of us in the cervical cancer space, when we hear Clinton Health Access Initiative, we smile because they are very supportive. The Dr. Kemi Da Silva gave her apologies. She was here, but for some logistic reasons, she won't be able to join us. She told me to assure us that she's with us in spirit, and because she's the founder of Women at Risk International Foundation, WARIF, which has been doing a lot in terms of cervical cancer and HPV vaccination. So, going straight to the point, we have like 25 minutes for this session, and we know that the main HPV vaccination is unique and different from the usual vaccines that we know, in the sense that vaccines are generally given to prevent infectious diseases, whereas HPV vaccination is given to young girls in their adolescence to prevent them from cervical cancer that they are going to have in womanhood, which is different from what we used to know regarding the normal vaccine. And I think that in itself is one of the challenges that shape some of the barriers and challenges in HPV vaccination we have across the country. So because HPV vaccine, the main goal is for cervical cancer prevention, so in our midst, I also have a cervical cancer warrior. So I want her to stand up for recognition, and will please recognize her. Mercy, please. Thank you. Because it is now a global norm that whenever we are discussing cancer and cancer prevention, survivors must be in the room. Unfortunately, it's a trying time for them, so there's a lot of challenge. So it takes a lot of courage for them to come forward. So the most important person, I know we might have representatives of ministers and all that, but the most important person in this room today, vis-a-vis the aim and of what we are having, is Mercy. And God bless you. Good. So, without wasting much time, we'll come to the panelists. So the first 2-3 minutes, each of us will give a detailed introduction of ourselves, what we do, and particularly as it relates to HPV vaccination. We know that the country has introduced HPV vaccine. If you have experience on what happened and the roles you played, that would be excellent. So starting from my immediate left, Dr. Chito. Okay, let me. Okay, yeah.
Talking
yeah.
All right. Good evening. I'm sure it's evening. Good evening or good afternoon, everyone. Welcome to this important discussion. My name is Dr. Chana. I am by profession an obstetrician gynecologist, but I own a women's health hospital in Abuja, Tabitha Medical Center, and Arabella Women's Health and Wellness. I'm also an executive director of Francis Felicia May Foundation, and one of the big things that we're known for is by partnering with the Primary Health Care Center, where we offer free care to women and vulnerable women, and of course pregnant women as well, children. So we're very also into our nonprofit, very into providing health care for vulnerable women and children. And I have a podcast show called Hercast with Dr. Chito. So I'm a very strong gender advocate. And so my show is about empowering women and equipping them with the knowledge and things we never talk about. I am trained in the US, and one of my I remember when I came back from the US to Nigeria was about 2007. And I was doing my residency at the time. And we actually did a study, incidence of HPV in Nigeria. And we wanted to see what the incidence was to compare to the United States. And we found out we had similar incidence of HPV in both parts of the world. And of course, the incidence of cervical cancer was extremely high in Nigeria. So we exactly, even based on that was done in University of Ibadan, that the differences was definitely because of the lack of screening. Now we've come far. We haven't really caught up with screening, but now at least we've got the HPV vaccine. I've been using that vaccine for 20 plus years. So I think being part of this now, moving back to Nigeria and being part of the system here as well and offering care, one of the main things I try to do is allay the myths. For something that's been around that long, if there was a problem, we would have known already. So that's why I'm happy to be here in the panel, because I'm a strong cervical cancer advocate, and I don't think women should be dying from something that is so preventable. It is the most preventable cancer. Thank you.
Thank you very much.
My name is Amos Paul Bassi. First, I'm an academic, a medical doctor by training, and a public health physician, and have been in this business from 1997, making sure the right vaccines are introduced in Nigeria, and working through the National Primary Healthcare Development Agency from that period to date. Most of the new vaccines that you have seen out in the immunization schedules, I was part and parcel of that development and the policies that had come out. And remember, I'm from the academic session, but I had to come in for time, and people keep asking me why. So it's most of the time pro bono, but from time to time, organizations will give you a consultant support. So we're here because of HPV, and from 2014, we'd written proposals to Gavi, and we wanted a single-dose vaccine that will carry the day. Didn't see the light of day until 2022 when that proposal got approved. And we wanted, like she alluded, to actually interrupt this transmission amongst the girls, because they have not had any experience yet. So it's a preventive action. And that desire scaled through, and we were given that approval to do it, and the World Health Organization, CHAI, JSI, and many other partners worked and rallied round with civil society organizations, rallied round MPHCDA to make sure the HPV introduction was launched in 2023. And remember, it happened just when we had an election, and new government came in, and we had a lot of battle trying to make sure we created the requisite awareness to various stakeholders, religious groups, traditional institutions, and even the young people, because they said, why are you bringing vaccines to us? And for what? They know that naturally vaccines are given to to children 0 to 5. Why now? And this is what we have been doing. We are on the Happy Project, and our work was to make sure that the last mile must have HPV vaccine there, and it must be given to those girls that have turned 9. We'll walk through, and we are doing it, but we are not there yet. So far, we know that over 14 million girls between 14, through the routine system, through the campaigns we have done together, have gotten this vaccine. And there's no country in Africa that had done this before.
We know that, Prof, if we give you all the time, yeah, all the things you have done, you can encyclopedia will not contain it. So we'll still come back to the good things you're doing. So, Abisola, please.
Good evening, everyone, or good afternoon. My name is Abisola earlier, I work for the Clinton Health Access Initiative, CHAI, where we support the MPACDA to introduce new vaccines into Nigeria. So since 2023, we've been supporting MPACDA to introduce the HPV vaccine. I think Prof has said most of the achievements, vaccinating 40 million girls. And just to put it in perspective, I think before Nigeria came into the game, across the continent, they've only vaccinated, I think, about 7 million girls. I was able to do 30 million in 1 year. So that's that we don't take lightly. I think something else to say just around HPV vaccine is during the partnership, there's a partnership to eliminate cervical cancer in Nigeria, and we supported to do the costing. We found out that primary prevention, which is HPV vaccine, costs just a sixth of the cost of eliminating cervical cancer in Nigeria. So this is just a push message as well to say, please advocate to young girls around you to please take the vaccine. It's effective, it's the cheapest way to eliminate cervical cancer. Thank you.
What? And I can from the panelists, I'm the least qualified, all of them. The National NPACDA, National Primary Healthcare Development Agency, is the government agency that is responsible for HPV vaccination. In short, everything that has to do with vaccine immunization, they are the, and all the three members of the panels have experience working with them except me. I am Ishaq Lawal. I'm a gynecologist practicing at Federal Teaching Hospital, Kebbi, and I'm just passionate about cervical cancer prevention because it's a disease that can be prevented. And unfortunately, for ignorance and so many things, you see a patient come to you that you know that if this woman had come 1 year before she's coming, there's hope. But this time around, they are coming at late stage where they're going to spend money, pardon my language, waste my time. Because when you are investing your time in treatment and you know that nothing good is going to come out of this treatment because of the late stage, technically speaking. So these are what made me become passionate about cervical cancer and what is driving my advocacy effort. So I don't have experience working with national primary health care. Now, back to the discussion, barriers to access, addressing HPV vaccination. Dr. Abisola, Dr. Abisola talked about the Clinton Health Access Initiative, support for national primary health care, and as he rightly said, with that introduction of HPV vaccination in the country, we shifted the pendulum for Africa. It was beginning to be a narration that maybe Nigeria, the African continent will be able to move towards elimination based on that output. So from your experience working with Clinton Health Access Initiative and the barriers that we have seen, because initially there was cost barrier, but currently now it's available free. But despite the availability free, it's not, we'll come to discuss some of those challenges where what national primary health care is giving is different from what we see on the field. But that's for another day. But now, based on your experience, what are the challenges gathering global support? Because your organization is very strong in terms of global presence. What are those challenges and what are the successes gathering global support towards overcoming some of the iniquities associated with HPV vaccination currently in the country?
Thank you for your question. I think I'll take the question in two parts. What are the challenges in just getting these children vaccinated? Like you rightly said, supply is not a problem. We have the vaccines in country. I think for this year, our coverage target is 9% to vaccinate 69% of 9-year-old girls. But the story then comes for the peculiarity of Nigeria. We have a huge population of out-of-school children. We have conflict-prone societies, hard-to-reach areas, maybe because of bad roads and all of those things. While school-based vaccination is working, there is a need to focus attention on these out-of-school girls, out-to-reach community. And like you said, for lack of better language, most of these issues we see in northern Nigeria. And you start to ask yourself questions around out-of-school girls. To even target them, you need to characterize them. Why are they out of school? Is it due to poverty? Is it due to early marriage? Is it culture? Is it religion? Until you start to answer those questions, you can't design strategies to address them. Otherwise, you just stay top level and do a one-size-fits-all. But people will rightly say that Nigeria is 36 countries and one. It's not. It's just one. It's not one country. Every state characteristics and their peculiarity is different. So there's a need to go to the grassroots to understand why are these girls out of school, how can we reach them with vaccine. A story we like to say often for the introduction of vaccine, HPV vaccine in Nigeria was when it was being introduced, one of the states we had thought we would see success in was in Lagos. And Lagos was then one of the states that gave us challenges, just like people saying, oh, you're trying to make their child more promiscuous, or you're trying to make them infertile. It's very, very important to stay ahead of the curve, to see what people are thinking and to stand ahead of it. And when it comes to out-of-school girls, you need to go down to the community level to speak to the community gatekeepers, the religious leaders, the traditional leaders, their parents, the mothers-in-law, all of those people. You need to speak to them, and that's the way we can tackle the barrier to reach out-of-school girls. Like I rightly said, in-school girls, yes, we are on a pathway to vaccinating them, but there's a big gap with out-of-school girls, and until we capture all of the girls, we are nowhere near eliminating cervical cancer in Nigeria.
Rightly said, we need to capture all the girls, and until we capture them, we are no way eliminating cervical cancer, and we need to know what are those factors. And to know those factors, we need data. So, Prof, I'll be coming to you shortly as an academician, as a research person, and of course, you'll be involved in this data. Abisola mentioned the fact that when we were planning, we expected Lagos to be one of these states with Sussex, and it was surprising that that didn't happen. So, based on your experience, wealth of experience and data, what are the data telling us? Because from my own lay, now not talking as an obstetrician, now as a public health person, could it truly be that the Lagos experience was the reality, while the experiences elsewhere were padded data? Because what we're seeing in the field is, in practice, really different from the figures we're rolling out. So, please, sir, can you use data to break this down for us, telling us from your experience?
Thank you very much for this. And it's important for everyone listening to note that when it comes to data in Nigeria, we have a system, and we call it the routine system. We use the DHIS, and it's through the National Health Management Information System. And thank you that you mentioned this. What happened to Lagos was, simply put, Lagos is a unique state, and Kano. They have to plan, they have to organize themselves, and they have to coordinate in using their own styles that other states in the country do not need to go through those routes. And this is what happened to the Lagos experience. Today, Lagos, when it comes to data, has they have one of the best data uploads that we have on the DHIS. So I think this is very important to mention. True, the database of Nigeria is housed in the Federal Ministry of Health, and what we do from the last mile, bringing them to the local government, to the state, and national. We rely heavily on what we call the networks, and this is where we've been having real challenge. So I agree that we're not there. We are just about 60, 65%. correct with our data. And that's why it's difficult for donors to support us. But if you go to the last mile, you will see that most girls targeted had been reached. But where is the evidence? This is the issue. Thank you.
Very aptly put. Now, Dr. Wana, you are in the private sector, and Abisola mentioned the fact that the target was 65 coverage, at 69% coverage. And we know that to eliminate cervical cancer, WHO recommends 90% coverage. And when we interrogated the data that came out from National Primary Healthcare, even the 80% coverage that we have is 80% of that 65, and that 65 is not even 65 of the total population, is 9. So there's a lot of issues there. And part of the thing they are talking about is the fact that we don't have resources to procure the volume of vaccine to go around the population at risk that requires the vaccine. And therefore, they made it that target. So, from your own experience at the private sector, what do you think the relationship between the government and private sector can be to bridge these inequalities? Considering the fact that even the government is not having all resources to give the vaccine for everyone, and if it's in the government, it's supposed to be free, but how can private practitioners come in to bridge that gap? Thank you.
All right, so first let me just do a kind of conflict of interest with this statement. I am also the Vice President of Guild of Medical Directors, so that being said, this is the organization of hospital owners, so I'm a private health sector advocate. When she talked about data, and we're talking about data here, the first thing I said to myself, I'm sure that doesn't include the private health sector. And in the private, and why I say that, and why this is very important, is the private health sector covers at least 60% of people in Nigeria. And when people think of the private health sector, even development partners and organizations, they think of, oh, these hospitals that, in quote, make money. But in my experience working in the rural areas, I find some places she's are not working, and the only thing that's serving that community is a private clinic. And so one of the biggest reasons there's a huge, I feel, gap is that there's not much engagement of the government and the private health sector. In fact, that's a huge gap, and a huge gap that's not being embraced where it concerns both those working in the government sector and development partners that tend to mostly focus their support to the government, excluding the private health sector. So I think that's one thing I want to put in front, as that's a huge barrier for people who attend private hospitals to access this vaccine at a reasonable rate. Private rates, the last time I checked, was about 15,000 for one. All right. So if you're going to come privately to get the vaccine, you're going to pay 15,000 for one dose, and then over the course of the 2 doses for less than 15. I guess it has changed now to 1, but then we're giving 2 doses, and some parts of the world we're still giving 2 doses under 15. You end up seeing the fact that, look, most of these people cannot say, of all things worrying them, they're thinking HPV, we don't bother with that now, let's just face what we came for. Yes, nobody will take the extra money to talk about, pay for a vaccine they don't know about as well. So a lot of when you talk about the gap here, there's a huge gap because there's a number that's missing. Data has been a huge problem in terms of really coming up with the real data because the private health sector is not included. Now, let me just add, let me finish. So I say this passionately, and that's why I said let me finish, because as adopting a primary health center that even works with the government, you find out that not every health center is connected to this initiative, okay? So there's a lot of reasons for why that inequality. How do we come in? Let's be engaged. Let's come in from different levels, not only in terms of data so we get it right, we get the numbers right, but also in terms of the fact that the private sector has a lot to offer the public space, right? I'm private, we're adopting primary health centers. That's a bridge. And many more will do it with support of the government. But most times when you engage government, they push back on you because of the mentality they have. So any policy being formed for HPV that's going to not engage the private health sector in a right way will not be non-implemented and will not be sustained.
Thank you very much. We hear you loud. Public-private partnership must be strengthened. Now, a bit of announcement here. We have the what we call MIE wants a feedback, and there are 3 pathways to giving that feedback. There's a barcode that's been shared. Scan that barcode and complete that to tell us how we have done very well. We have done very well. Yeah. So that they can invite us next time. Yeah, okay, but that. So then you can use the digital screen in the foyer, and then you can use the research assistant tablets. These are the 3 pathways to which you will be able to give feedback to them. And that's one thing with PIC. They take your feedback very seriously, and they incorporate it into, if you want something, if there's anything you want to be improved upon, or you want something to remain for the 2026 Gender Summit, please include that in your feedback. Now we want to go to the to you for feedback, so that it's not only we are here by selection, and I'm sure there are a lot of people within the participants that have ideas, that have things to share with us. So we have just 5 minutes to do that. So I will start that with Mercy, being a survivor, give her the preference. Mercy, if you have opportunity to meet the president, for example, or of health, what requests will you want to make based on your experience, challenges that you have gone through?
Okay, good evening, everyone. And thank you for the question. I would like him to because there are most people out there that doesn't have I don't know how to put it, the privilege or the capacity to receive a better treatment based on money. And mostly if you go to the villages, aside from Abuja, if you go to the villages, you see most people suffering from cervical cancer, but because they don't have the resources, most of them are dying. Some of them, they'll just go to some random hospital, because it's not all the hospital that has the facility. So they'll just go there, and most doctors, let me just say, due to their selfishness, they'll just be sorry. So due to their selfish reason, they'll just be treating them like it's just a normal thing that they can, for me, I would like them to, if they can raise, something create a funding for them, it will be better, and at least bring more awareness to those people that doesn't have knowledge.
Thank you very much. And yeah, what Mercy has just talked about is about the myth that we think that a lot of people don't access care. My experience is that most people that don't access care is mainly because they don't have the money. Nobody wants to die. So all this is not my portion, or you go to traditional healers, or you go to church, you go to mosques. It's because you don't have the money, and then you are hoping against hope. You don't want to lose hope, so the only place that gives you hope, you go to. So ladies and gentlemen, please, if there's any person that have comment, questions, no comments, no questions, I mean, just to give us, yeah. Let the people, 2 people, please. Raise. We are going to take 2, just 2.
All right. Good afternoon, everyone. My name is Ayomide, and I work for NOI Polls. Yeah. I actually currently lead a project called HPV Campaign Research Sprint in Lagos State. And just 2 weeks ago, we were in Lagos conducting focus group discussions, trying to understand from parents, educators, and health workers what's hindering them from allowing their daughters or children, girls in their care, to take the vaccine. And we see that there's really a gap in terms of awareness. Many people actually don't even know what HPV is, least the vaccine. Well, and I think that we need to do a lot of more work, even debunking the myth or the norms around the essence of taking vaccine. I heard from the panels as well, a panelist rather, saying, yeah, for some people they feel like, oh, you want to reduce the number of eggs in girls so they don't give birth, and why is it only girls? Why are we not including the boys? And why is it not free? In terms of cost as well, people are not willing to take it because they barely even eat 3 times a day, so they can't 15,000 naira per dose for those that are already above the age. And they were plead to the government that, okay, maybe we can increase the age bracket so it accommodate more people, or maybe we can also make more awareness and you leverage the gatekeepers, like she had said, the community gatekeepers, traditional leaders, the churches and pastors and the imams, so that they can come into those meetings or community gatherings and invite health workers to educate people about the vaccine and also about the disease itself, so that also creates a demand and generates demand for the HPV vaccine. Thank you.
Yeah, thank you very much. We hear you clearly. I hope we are taking OPIC to translate what is happening to policy. Talk. The next question. The next hand. Okay.
Thank you very much. Thank you, panel. Sorry. Okay, so I wanted to come from the angle of the religious aspects of it. HPV vaccine, or rather, cervical cancer is only gotten basically through sexual intercourse, right? And at that age, most people have reservations, even when they have awareness about what HPV virus is. It's just as good as sharing condoms and lubricants for intervention. You hear, oh, you're encouraging young girls to go out there and do. So I think one of the ways to break that barrier is to go through the religious leaders themselves, so that we have this type of awareness being spread even in the religious sector, and show how this prevents public health issues rather than necessitating the moral failure that they believe that comes with it. So that's my contribution. Thank you.
Thank you very much. Very, very important. So I'll go to, time is fast spent. They've shown us that we are already over time. But just to address that issue of transmission is very important. And unfortunately, I've seen cervical cancer in in a housewife, and the husband was beginning to say, where did you get it? And then I'm sure Mercy will tell you that a lot of people have been harassing her about age of sexual debut. And I have, not because he's here, I've interrogated that so well. We know that data says that age of sexual debut now, that is when first sexual contact, is now around 9, 8, 10. But Mercy never started until she was 17. Yes, she's with cervical cancer. So what I'm trying to say is that cervical cancer and HPV does not have that direct sexual relationship. Unlike the normal sexual transmitted diseases that has to do with true sexual intercourse, penetrative sexual intercourse, HPV is contact. It's actually more of a contact transmission than sexually transmitted. Because I can shake you, because I have HPV. HPV is ubiquitous. I can shake you and I have HPV on my hand. You go to the toilet, wipe yourself, and you self-transmit yourself with HPV. So that language about sexually transmitted, we need to play it, is one of the stimulants for the myth around resistance for the HPV. I just felt I should add that. I'm sorry I'm taking time of my panelists, but panelists, please, 2 minutes, your last words. General talk you want to give to the people, headlines you want to hear about HPV come next year, just general take about HPV. Thank you.
Let's give the private sector first.
Okay. I think I love the inputs that we've heard today, and I just want to give my 2 minutes. The first thing is that I think that we missed something also very important here in any policy is education of the providers and healthcare workers on HPV itself, because coming from that space, there are many people that don't even know that about HPV, and they're the ones patients first, right? And in terms of the myths, one of the things that's very key for advocates that are in this room is you have to explain that HPV is like hepatitis B. And when hepatitis B was first introduced into Nigeria, there was so much thing about sexual immorality, right? Now it's part of the normal vaccination schedule. And our aim as advocates is get HPV to be part of the normal vaccination schedule. And it will be, because it's even in biological sense, I believe it's almost the same way of hepatitis B. All right, and so therefore it has nothing to do with infertility. I kind of killed that myth. That's the one that they talk about most when they even come to our practice, even the most educated mom, right? So that's the main thing here. And number two, we talked about culture and immorality. I always talk to them about that's the same feeling you get. I'm a mother as well. When you see your 8-year-old with breasts, you're going to have that thought, oh my God, we're getting there. So there's a natural fear. And as a mother, I may not take my 9-year-old easily just to go get a vaccine that may be something connected to sex. So it's all about education, about how to normalize HPV is what the idea is. Do you understand? Other parts of the world, the average age is 11 and 12. Hopefully Nigeria gets to the point where they give these free vaccines to a wider age range, and they will definitely get a better response, because parents tend to feel better at 11, 12. Okay, they're getting into secondary school. Okay, makes sense now. And so it's very important that to reach good targets of eliminating 95%, the range has to definitely increase. All right, and then for you, Mercy, I will say what she's saying is so true. Those of us that work in rural areas see people suffer for cervical cancer, and the treatment of cancer, whether it's cervical or otherwise, is expensive. It's expensive even for that person in middle class who's doing a normal job. It's expensive. And we don't have a lot of organizations doing cancer funding for these kind of things. So it's hard, and you watch people die, literally. And I hope for your sake that you have, people can come together and help you to get through. You're too young to go through this. You're actually in the minority, and I hope that you get the help that you get from here. I will leave one thing. A vaccine in a fridge is just that, in the fridge, but the empowerment of vaccine, and for what our whole idea is to get that vaccine to the arm of a child to save them for cervical cancer. Thank you.
Thank you very much.
Thank you. Having heard what Mercy has said, what I can advise is our members of the National Assembly and all that are in leadership position should make this issue of preventing the preventable diseases funding to be increased, because really, 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 we cannot rely on donations to control and to interrupt the transmission of diseases. I'm talking from a 25-year experience on this. We need more commitment, because data that you are seeing, you can only use the data based on what was given you, that you have to give a feedback. And this is what we need to do, because it's giving misinformation, disinformation to the global community. What we are doing as Nigerians, we are a great country. The health workers in the private and public sector are doing great, but it could be better if we have access to what we call commodities, essential commodities, essential medicines. Thank you.
And thank you very much. And Mercy, thank you for you're very strong. And yeah, I think one final word for me would be cervical cancer is preventable, and all you need to do is take the vaccine. For girls 9-year-old, it's free. The government of Nigeria has paid for it. So if you have 9-year-old girls around you, please advocate for them to get the vaccine. There's a lot of rumor around vaccine, even globally. You'd be amazed, like countries like America, that we think they're very forward-thinking, and they're the ones in the front face of a vaccine rumor, right? It's very important for all of us in this room. We are educated. We know what the vaccine is doing. Please, let's advocate for more girls to take the vaccine. It doesn't need to get to the point of tertiary treatment. We can stop it from primary prevention and make the burden less for us. We know that Nigeria is a very poor country, So the cheapest to eradicate cervical cancer still remains vaccine. So yeah, thank you.
Yeah, thank you very much. And my last word will be, we are trying to do, I'm not good with social media and this GoFundMe thing. Currently, Mercy is trying to access care at National Hospital. There's this talk that there's a free cancer treatment cancer health fund. She's gone to National Hospital. Just investigation alone is 375,000 that they've told her. So she's trying to raise a GoFundMe for. So if there's anybody that has experience with GoFundMe, please reach out to her and support her to do a GoFundMe so that she can have a treatment. She's too young to be allowed to, she lost reproductive to cervical cancer. She shouldn't lose her life to it. Thank you very much.
Photograph, group photograph. So there's an important, there is an important session going on now in hall. Yeah, leveraging the 3 Ps. And I'm sure that you will enjoy that session. So we encourage you to please go to the main hall to that session. Thank you. Well done.